Hi, and welcome back to part 2 of our 3-part lecture series on ethics, practice management, and medical legal issues. I'm Josh Lumley. Let's go ahead and dive in. So this lecture, the modules include preventing, minimizing, and controlling risk, the components of a risk management and safety program, everything from the clinician's perspective regarding medical legal management, and the impaired or disruptive provider. So let's talk for the next 3 to 5 slides about preventing, minimizing, and controlling risk. So there are 3 overarching parts: avoidance, fail-safe steps, or red rules. In terms of avoidance, it's more a question of don't do it. High-risk procedures. This is a patient who has took an ACE inhibitor and who has now has a swollen tongue and angioedema, airway compromise. Should I do this fiber optic intubation down in the ER? No. Let's bring this patient up to the operating room, have a trach tray on standby, an ear, nose, and throat surgeon next to the patient, and do the fiber optic intubation there. So avoiding unnecessary risk. Fail-safe steps. If you must do it, you've got to do it safely. So if you're going to step off the space shuttle into space, you've got to wear a moon suit. And then there are red rules, which are rules that should never be broken. So sponge counts. If there is if there is a sponge count that does not match up, then we cannot close the abdomen. We have to get an X-ray. So this involves maximizing team dynamics. So utilizing crew resource management. All of us have done CRM training at our home institutions, and of course participating in crucial conversations in a just culture. It also involves utilizing industrial organizational psychology and human factors engineering. So looking at the environment, looking at the equipment, looking at the supplies, and determining with an ever-questioning attitude or an ever-explorative attitude of can this be improved? Will this pose a risk in the future? And then, of course, cultivating a culture of patient safety. So we talked about just culture during lecture 1. So when a bad outcome occurs, it's not a matter of that individual acted inappropriately. It should be more of a systems-based approach, looking at the system and determining what allowed this error to occur. This avoids giving blame on one individual, and it implies having a learning, ever-improving, process improvement organization. So red rules, these are rules that cannot be broken. So you can't have a ton of them. You can only have a few, and they need to be very, very easy to recall. So they are associated with processes that can cause serious harm to patients or providers if they are broken. If I close the abdomen and my sponge count has not been reconciled, now I'm taking the risk of closing an abdomen and having a sponge, a retained foreign object in this patient. Timeouts, where do timeouts fit in this? Obviously, we need to know about allergies, we need to know about blood risk, we need to know if there's blood available. That's why timeouts are so important and really should be defined as a red rule. So what are the components of a risk management / safety program? A just culture, as we referred to earlier, is part of the proactive response, not the reactive response. So just culture refers to a way of thinking that promotes a questioning attitude, and it's resistant to complacency, always looking to improve. Committed to excellence fosters both professional, personal accountability, and corporate self-regulation in safety matters. So everybody needs to be able to, quote, stop the line. So this goes back to the Toyota production system where any person, whether it be the manager on the floor or the technician that is installing doors on the automobile, needs to be able to stop the line, the procession of the supply line and the procession of the conveyor belt to be able to say what is happening right now is not safe. I'm calling it out and we're going to stop the line here. Applying that to the operating room, anyone, whether it be a janitor, a surgical technologist, an anesthesiologist, or a surgeon, needs to be able to say, stop, we have not done X, Y, and Z. So the components of a risk management and safety program involve A, management, being able to have a prolific hazard analysis where you're constantly evaluating what conditions exist in the current state, ongoing inspections on the floor, ability to anonymously report hazards, constant accident investigation through the use of something as extensive as a root cause analysis or just a quality improvement program, controlling hazards, and participating regular training for providers with safety and health training. So from a clinician's perspective, let's talk about that now. When we're evaluating medical records and utilizing medical records, it's tough to have a medical record that is 100% perfect. But when you have an adverse event, it's really, really critical that you document all of the events that just happened. So extract yourself from the scenario if at all possible and create a timeline of the facts. Give a clear idea of what happened before, during the visit, or the procedure. Obviously, you may be unclear. You may not know. The patient coded after induction. I don't know if it's anaphylaxis. I don't know if it's an MI. I'm not sure what it is, but the patient is now intubated in the ICU. This is what happened. These are the medications I gave. This is what happened with the event. This is what my response. Give an idea if you have an idea of what will happen after the procedure. And then support your necessity and the appropriateness of your care provided. Obviously evaluating your charting and all the documentation and billing that supports this procedure for medical legal purposes. And then of course it's going to be evaluated by standards and accreditation bodies for compliance and quality and evaluating the performance. And finally, having a robust, complete medical record provides credibility to you, the documenter. Question. A majority of malpractice suits are A, settled, B, adjudicated, C, dropped, D, frivolous, or E, fishing expeditions. Excuse me. And the answer here is C, dropped. So the majority of malpractice suits are dropped not because they're frivolous, but because as more and more information comes to light in the discovery process leading up to deciding whether or not this goes to trial, a plaintiff's attorney may realize that the case is not as strong as they originally thought, not the slam dunk that they thought they had before. So in more than 58 of the cases, they are dropped. 26.6, so a full quarter of those cases settled, and 14.8 cases are adjudicated, so go all the way to trial. Many cases are decided on the basis of documentation. So that can be, there's not enough, documentation is inappropriate, it's not timely, it's not dated, there's not continuity, it kind of is bouncing about. You can't follow a clean pathway or a clean timeline of events. And then, of course, there's the quote, which is, if it's not documented, it didn't happen. So what are lawyers going to look for? They're going to look for gaps in documentation, whether that be time, effectiveness of intervention, which is why after something happens, it is important that you document and you've got a good timeline of those events. A lawyer is going to look for inconsistency over time, across disciplines, handoffs, etc. Where there are discrepancies related to standard of care issues. Was procedure or protocol not followed? And remember, due to HIPAA, anyone that the patient authorizes can look at that medical record. It's not just an attorney. So the record needs to speak for the healthcare provider, needs to speak for the patient, and of course it needs to speak by itself. And it can be created by one party, and of course it can be used by both parties. So, okay, Josh, how much detail is enough? Do I need to, I'm coding a patient. How am I going to be able to document while coding the patient exactly what's happened? So, You need to know when you added new medications, when you decided, okay, I'm now going to try amiodarone, or I'm now going to try vasopressin, whatever that may be. Patients declining routine preventive services. So was there multisystem organ dysfunction and inadequate preoperative care? Patients that are not compliant with medical regimens or missed appointments, had a hemoglobin A1C of 15 preoperatively, whatever that may be. So were there attempts to follow up and reschedule? Patients that make treatment choices on their own or alter your recommendations on their own. You need to be able to document the specific reasons why a patient did not follow that recommended regimen or take a prescribed medication or was non-compliant. Try to document how much time you spent in educating the patient, and of course, ideally, in an inpatient clinic type appointment, what are the notes related to the phone calls, family members that were contacted, emails, letters, etc. So why do we already established that about 60% of cases are dropped, but a full quarter of them are settled. So why do suits settle? So after the fact, were medical records altered? Was documentation poor? Was the physician confrontational, problematic, have a bad attitude? Did the physician's statements based on treatment, were those insupportable? Did physicians working together or providers working together demonstrate hostile staff? And then finally, there's a reasonable expectation that you don't feel comfortable if this case is adjudicated, and typically the fees associated with a adjudicated court procedure will actually be higher than that of a settlement. So when you factor in the verdict, the court costs, and the attorney fees, it's just cheaper to settle than to take it to court. So what are some of the malpractice claims that are out there? So surgical mishaps, a quarter of them. Misdiagnosis, 24%. Incorrect treatment, 20%. Medication errors account for about 8%. Obstetrical mishaps, 7.5%, and then the lump of others accounts for 16%. So according to the U.S. General Accounting Office, communication failure contributes to 80% of all of all malpractice claims. All right. So for the last half of this lecture, we're going to talk about impaired or disruptive behavior. This is a huge focus now, both for the ABA, but all of our hospital systems like that, about being good teammates. And certainly we have been, I'm sure, in operating rooms where not everyone has been a good teammate. So let's do a deep dive into that. Disruptive behavior, an aberrant style of personal interaction. So quoting the disabled physician put out by the American Hospital publication, with physicians, hospital personnel, patients, family members, or others, any type of interaction that interferes with patient care or could be reasonably be expected to interfere with the process of delivering good care. So typically that involves poor communication, badly affecting morale and the overall function and interaction of the healthcare team. So some of those examples might be profane, disrespectful language anywhere in the healthcare setting, demeaning behavior, referring to hospital staff as stupid, idiots, the man is putting me down. This is a big one now, particularly for all of us in the operating room where perhaps we are not as professional as we should be. Sexual comments or innuendo, inappropriate touching, sexual or not sexual, racial, ethnically oriented jokes, outbursts of anger, throwing instruments or charts, criticizing hospital staff in front of patients or other staff. These might be negative comments about another physician's care. Oh, I'm really glad you came to me because that guy over there, he was not taking good care of you. He totally missed that diagnosis. Boundary violations with staff and patients, sexual or non-sexual. Comments that can undermine a patient's trust in a physician or the hospital itself. Inappropriate charts, i.e. directly calling out another provider in the chart or calling out another provider's therapy and treatment in the chart. Unethical, dishonest behavior, difficulty in working collaboratively with others, failure to respond to repeated calls, inappropriate arguments with patients and families, and of course, after having been given corrective action, the patient is either defensive or has a poor response to it. So in a 2004 survey, the majority of physician behavior problems in the organization, the answer, so the question stem was, majority of physician behavior problems in my organization stem from : and the top two answers were conflicts between physicians and staff members, and physicians who are feeling frustrated and vulnerable due to changes within the organization. Not, we feel like our clinical care is poor, we feel like our training is bad, all related to conflicts and physician distrust. So physicians in my organization are generally treated more leniently than other organizations. That answer, 63.2 respondents said yes, they are treated more leniently. That is not a just culture. And that is, of course, something that is in the process of changing now. So how do we manage that behavior? What's the soft science related to managing a bad actor? So there's got to be formal behavioral standards that emphasize respectful and safe environments. Saying that is inappropriate. Our culture, our just culture, says you cannot talk to me like that in the operating room. It's got to be able to be. You've got to be able to give feedback confidentially, and then a response to it has to be timely and prompt. We have to be carefully manage this at every stage, so there's not the opportunity for a bad actor to be vindictive. It's got to be fair and supportive. It's got to be based on objective data. So there can't be like, somebody who's on a mission, to bring down one individual. And it's got to be hard, not on the person, but hard on the behavior. Obviously, you start off with some graded response. Verbal counseling, written counseling, termination, whatever that may be. And ideally, it's going to be informal and non-adversarial. Hey, let's go have a cup of coffee. This is what I've heard in the operating room about something that you say. That's not appropriate. We don't talk to people like that. If at all possible, and if necessary, you may need some outside legal counsel. And then certainly, if you may need to do a psychiatric assessment. Maybe this is a mood disorder that's being unmasked. And a multidisciplinary peer review may determine fitness for duty if the patient needs assistance, if they need rehab. Which of the following does not offer protection for the physician with an impairment/disability? A, the ADA, the Americans with Disabilities Act. B, the Impaired Physicians Alliance. C, state-run physician health programs. Or D, the Rehabilitation Act of 1973. And the answer here is B, the Impaired Physicians Alliance. So the ADA, the Rehabilitation Act of 1973, and state-run programs, those all offer protection for the impaired physician. And while there are support groups for impaired physicians, those don't offer protection. So what is impairment? It is considered to be any loss of use, derangement of any body part, organ system, organ function. So permanent impairment, is permanent impairment that there's not going to be any substantial change in the next year. My eyes are permanently impaired. Maybe I could get LASIK to correct it. But with or without medical treatment. So permanent impairment, medical treatment, not medical treatment, it's not going to get any better. So the Americans with Disabilities Act says physical or mental impairments that substantially limit one or more major life activities. Emotional, sensory, developmental etiologies. These can be congenital, they could be acquired, they could be acute, or gradual, ALS. Disabling diseases disabling diseases in your healthcare organizations can elicit blame and stigmatization. So maybe someone has massive morbid obesity, or may elicit compassion and sympathy. So new onset seizure disorder. But folks that are disabled, that have a disability, are a protected class per federal non-discrimination law. There is disability discrimination that has been present for anesthesiologists, but it is protected under both the ADA and the Rehabilitation Act of 1973. Which statement regarding anesthesiologist impairment is true? Common problems like hearing and vision loss are rarely a problem due to amplified stethoscopes or glasses. Anesthesiologists with seizures should not practice. Fatigue by itself or by exacerbating other conditions can be a patient safety issue, and there should be safeguards in place. Or D, due to the anesthesia being a fast-paced field, only 15% of anesthesiologists are older than 55 years of age. And the answer here is C. Fatigue by itself or by exacerbating other conditions can be a patient safety issue, and there should be safeguards in place. So hearing and vision loss can impair the clinical practice of anesthesiologists, but a well-controlled seizure disorder does not preclude clinical practice. Of those answer choices, fatigue has been demonstrated to be an independent predictor of impaired performance. So there are three overarching issues that surround anesthesiologists that are impaired. Number one, we need to be able to, anesthesiologists ideally have access to short-term and long-term disability. So they may be seeking disability insurance benefits after establishing an impairment. If it is a reversible cause, can they return to practice after that injury and illness? And then there, of course, is the ongoing question of the peer review process, which is whether a colleague with limitations should continue to practice. So what are some of the common impairments? Loss of vision, loss of hearing. Maybe a person like Charlie Sheen here has neuropsychiatric disorders or substance abuse. And then I've got highlighted here over-fatigue and work hours and the aging anesthesiologist. So it's not just the general population that's getting older. The field of anesthesia, the age curve is shifting to the right. And of course, we have tried to improve work hours with medical trainees, but oftentimes the hours associated with being on call and working post-call, etc., can contribute to over-fatigue and some impairment from a clinical judgment standpoint in the OR. So loss of vision, obviously you can have glasses. So if you don't have glasses, you can have medication sorting errors, you can misread labels. Of course, if you've got really bad vision, maybe you can't even see the vocal cords. So is this an acute loss or chronic impairment, and what is our therapeutic intervention to be able to fix that vision loss? Loss of hearing. So oftentimes hearing loss is not something that an individual even knows they have until it's pretty far progressed. So one study demonstrated that 66% of anesthesiologists had abnormal audiogram measurable over all audio frequencies. So what does this mean for us, and how can this impair us? Well, maybe we can't hear suction over music, or maybe we don't hear our beeper or alarms, surgical equipment, or pulse oximetry. So oftentimes, to combat that hearing loss, we either need to turn up the volume or we need to set our equipment alarms to a frequency that's easily detectable for the provider. Now let's shift over into neuromuscular disease versus psychological disorders. So some of the neuromuscular disease which affect everyone, of course, Parkinson's, ALS, MS, they have variable penetrance, or at least MS does, as well as Parkinson's, both severely affected versus minimally affected. ALS, of course, is a progressive disease. Ultimately, that leads to death. Psychological disorders, depression, bipolar, Asperger's, a person who's high-functioning autistic. So in most of the cases, an anesthesiologist can evaluate the progression of his or her disease, his or her ability to function in a workplace, and can monitor the progression to determine that am I safely able to administer anesthesia. With psychiatric, the prevalence of psychiatric disorders is really unknown amongst physicians. Anxiety, depression, personality disorder, disruptive behavior. It's not really felt to be any different from the lay population. But there is a relatively high preponderance or prevalence of dependence, drug dependence, and suicidal ideation amongst physicians. So let's talk about anesthesiologists that have diverted and abused drugs. So 6% of those had a primary psychiatric diagnosis. There is an observed association between personality traits and the drug class that is abused. So folks that have ADHD are more likely to abuse amphetamines. Folks that have depression, anxiety are more likely to abuse opioids. Some of the psychiatric issues, of course, severe neuroses, psychoses, like frank delusions, are going to be incompatible with safe practice. But if a person is well monitored, has a controlled disease, controlled depression, bipolar disorder, that should not be a contraindication to practice. And cognitive and motor effects of those psychotropic medications may also require monitoring. So maybe they are sedatives, or maybe they are drugs which induce extrapyramidal symptoms. Seizure disorders. So etiology, the frequency, the severity of seizures, and the compliance and adequacy, compliance of treatment regimen, as well as the adequacy of treatment, is going to determine if that person is able to continue to practice or if they require a restricted practice. If the person has sleep deprivation or the circadian disturbances make seizure activity worse, it is advisable to take that person off of a call schedule and only give them daytime work. What we see is that most states, and you can look up your state online, most states, in order to drive, require 6 months of being seizure-free. So again, here in Illinois, in the state of Illinois, what we see is that you got to have 6 months seizure-free, and you've got to have, and the medical updates is going to be at the discretion of the medical advisory board. Fatigue, independently predictor of impaired function, but it can independently cause seizure disorders, or it can exacerbate underlying seizure disorders. So obviously we need to be aware that fatigue can unmask seizures or can make them worse. So now let's just hop in very quickly into the aging demographic of anesthesiologists. So between 1994 and 2006, of the ASA members that were over 55 years old, there was a 5% increase from 22.8% to 27.7%. So it's this thought of the encroaching circle of incompetence. Somehow as you get older as an anesthesiologist, you are a less skilled anesthesiologist. And some of those thoughts, while incorrect, are grounded in this idea that there are progressive and irreversible neurologic and mental capacity changes as well as technical changes. The reduced ability to respond adaptively to environmental changes, and then other comorbidities which become more common as a person gets older and somehow worsen a person's performance. So with the effects of aging, the negative sides of it are cognitive. There is an age-dependent decline of knowledge base and performance on recertification exams across all medical specialties. Typically, as one gets older, they're less able to perform effectively in stressful environment, react appropriately in stressful environmental conditions, and there is a slower process for that individual to take incoming information and make complex decisions. So attention-related tasks, scoring across a whole host of measures decreases with age. And obviously, as we know with anesthesiology, vigilance is the hallmark of it. The ability to sustain vigilance and monitoring for long periods of maintaining attention is critical. So how does that work, and how do we reconcile that in our older anesthesiologist population? Obviously, the good side is that technology is getting better, and that there is a very positive effect of technology for helping older providers to stay in the field longer. So of course, with age, while technical ability may decrease, experience and judgment actually get better with age. One study found that with surgeons over the age of 60, that was not a predictor of operative risk in 5 of 8 procedures studied. So of the big 5 to 8 procedures that are typically done, age greater than 60 was not predictor of risk. The only time that risk increased is if that older physician attempted a procedure that they do very, very rarely. So a general surgery procedure that they haven't done since residency, the risk factor increases dramatically. And that is it for part 2 of our 3-part lecture on ethics, practice management, and medical legal issues. Thank you.